We're now continuing our discussion on ischemic heart disease, but we're moving on to unstable angina and Prinzmetal angina. We just covered stable angina. So ischemic heart disease with unstable angina is essentially that it's pretty much the same as a stable angina, except for it's not relieved with rest. Before, with a stable angina, the person could just stop running around and their myocytes would get enough oxygen from blood and they'd be okay. But in this case, the chest pain is occurring at rest, and the only thing, the main thing that you give them, you notice here, is that it's relieved by nitroglycerin, whereas stable angina was relieved by rest or nitroglycerin. So in the case of an unstable angina, essentially what you have here is, here's your coronary artery, here's where it's going into the heart or whatever, and you have atherosclerotic plaque. Okay, atherosclerotic plaque is blocking off greater than 70% of the blood flow going into there. And in the case of an unstable angina, there has been a rupture of this plaque, which has opened it up, which has exposed some collagen, and it's starting to form a thrombosis. Okay, and it's an incomplete occlusion of the coronary artery, or the thrombosis isn't blocking all of it, but it's enough that even at rest it's causing pain, and that pain is not relieved by rest. And so this actually also causes reversible injury to the myocytes, meaning that myocytes swell, but they're not necessarily completely destroyed or completely damaged. That you'd also see the ST segment depression again. And one of the reasons for that is because, like I said before, if you have the epicardium, you have the myocardium, and you have the endocardium, the blood vessels coming in here, going in, it's occluding here and ends up blocking off, and it's subendocardial infarction, or not infarction, but ischemia, and that shows on the EKG as ST segment depression. So normally an EKG would look something like that. This is the ST segment right here, but you'd have ST segment depression. So it would look something like this. Okay, so that's depressed. Go here in the T wave. So with this, there is definitely a high risk of progression to a myocardial infarction. And the reason for that is because of this thrombosis. If this thrombosis were to just grow a little bit bigger, it could completely block off this coronary blood vessel, and you'd have a myocardial infarction in that case. So now we're moving on to a Prinzmetal angina. So Prinzmetal angina, this is different. This does not involve an atherosclerotic plaque necessarily. What this is you have this blood vessel going into your coronary artery, whatever, going into your heart, and you get this, for some reason, you get this vasospasm. So the muscles in your blood vessel clamp down, and it narrows this significantly to the point where not very much blood is getting in there. And it's not related to exertion or anything like that. This other one was related to exertion. This is could just be a random event. All of a sudden it just clamps down and you're, you're taking enough air, but you're not getting enough blood to your heart, And this leads to episodic chest pain that's unrelated to exertion. It's, again, reversible injury to the myocytes. So, these myocytes in here, that they would swell and everything, they wouldn't necessarily be totally damaged or totally destroyed. On an EKG, there is ST elevation, and this is due to a transmural ischemia. So before up here, I said this was subendocardial ischemia. This is transmural ischemia. So again here, if you have the epicardium, the myocardium, the endocardium, before I said, the block ends up being in here somewhere. In this case, the block is all the way up here. So this whole thing, this whole blood vessel becomes blocked off. So it's transmural. And when you get a transmural, when you look at that ST segment, it's Q, R, S. Here's the ST segment. There's a J point. Here's the ST segment here. This thing is actually going to be elevated like this. That's evidence of a transmural. Okay. And what's going to relieve this thing? You could relieve it. Well, what would relieve it? Nitroglycerin. That causes blood vessels to expand. Now, if you remember, what is it that's causing these things to tighten down in the first place? Well, calcium. It's exposed to calcium, from the endoplasmic reticulum, and this calcium is going to cause it to tighten down. So if you have a calcium channel blocker, then that will cause the muscles to relax in your blood vessels here. And so amlodipine, diltiazem, felodipine, or verapamil, or nifedipine, any of those drugs like that, calcium channel blockers, are the kind of drugs that you'd want to use.